heads up.
Why don't we
And
bring
you
a
can
phone down there?
Try, but we're going to try to get you closer to Cindy's lead. Sorry,
Okay,
Cindy.
Okay. So the first thing I wanted to go through, which was similar to what Joyce has gone through in the past, is the benchmarking piece. And I don't know if I had sent it out, so I don't know if everybody has a copy of that. But
We do,
we
Cindy.
okay, we had put in an extra line, one for the Lee County, and then comparing you, when Joyce had done it previously, it was always comparing it to the public sector book of business. We added an additional column in there so you can see how you stack up with the other members of the IPVC group. So you can see that actually you are running in general a little bit better than the IPVC in general. So where the admissions per 1,000 for IPVC is 62.49, you guys are only at 62. Your dollars and the length of stay are considerably shorter. Even on your length of stay for your surgery, that's shorter as well. And then the outpatient visits per 1,000 are higher, and they're quite a bit higher than the IPVC, but sometimes that is not always a bad thing, because if people are going outpatient, it's usually avoiding an inpatient stay. So it's still, it's still considerably higher. So it's something to look at. But not something, that I would be immediately worried about. Your emergency room, which are the other thing that we usually look at, are quite a bit lower per 1,000. And the average pay per emergency room visit is quite a bit less. Now, some of that because of IPVC being both in the metropolitan area as well as in other areas of the state, some of it is, geographical, but it's still good to see that you guys are lower. And then on the professional side, again, you're showing up quite a bit better than on the physician's office visits. On the outpatient mental health, you are incredibly lower. And then on the chiropractic visits, you are ever so slightly lower. You are more in line with the public sector piece. The IPVC is almost always higher than that. And you actually more closely match the public sector piece. And then the chiropractic visit charge, again, is lower. So all in all, it's a very good story for you. Your prescriptions per 1,000 are lower. The average paid per prescription is higher. And that is probably due to, I noticed that there are some ongoing conditions, and we'll get into that with the other piece. But that is also a better story in total than what the book of business is running. All right.
Okay.
So any questions on that piece? Now, did you want me to get into the new piece, or you want me to wait for new business to get into the new piece?
What's that? What's they saying? Well, she was going to, that was, I think the new piece was going to be, that was, well, actually, no, go ahead, because the new piece is part of the update. So go ahead, Cindy.
Okay, all right. The new piece, the first page will look like it has two triangles, and it shows what this is. Again, this is on the overall book of business, and then so that it is the larger book of business for Gallagher in total. That gets you your benchmark, but then it shows where you compare to, on that whole book of business for the benchmarking. And it's a fairly new form, and it, as you can see, will go into a little bit more granular detail regarding the specific claims, and then some things that they call gaps in care, which those gaps in care are things that, we can figure out, okay, how can we address these so that you close the gaps in care, and by doing that, you are hoping help with the health of the member. So the very first piece, that's the two triangles, shows the healthy is, benchmark is 54.8. You guys are at 54.4. And then the one that is the triangle going down is the actual healthcare spend. The other is the enrollment. So the spend, you are at 11.8 versus the benchmark of 14.5 for the healthy people. So that's fine too. The chronic, you are almost right in line on the number of people, and you are quite a bit below on the spend. And it's only in that high cost piece that you are way over in this in spend and in the number of people. And that splits out the high cost. Then if you go to the following page, the risk stratification framework piece, it's taken the total population. The low cost people are the people at that bottom rung. And, or they classify them into A, B1, B2, and C. The low cost people are your C people. What you really want to do with there is just make sure they're doing the same thing that they're doing currently, because obviously they're healthy. So just maintaining healthy behaviors so that they can stay in that rung is the idea. For the chronic conditions, that would be the one step up, the B, they separate that into high care gaps and low care gaps. So those are the things, okay, this person does have a chronic condition. Are they monitoring it well? Are they doing the things that they should be doing to keep as healthy as they can? That's the low care gaps. The high care is the ones that, okay, we got to re-engage them because we need to get them doing things that are more positive for them. And then obviously the high costs are the ones that were in that top piece. And that's where you were kind of the outlier. The group A, you have 5 members that are in that group, and your total dollar spend for that is $429 almost $1,000. So then next we're now stratifying this down into the members in group A. Again, by the time they're in that, you can try and get them to do some healthy behaviors, but it means they have at least one major thing going on. Many times they have comorbidities that will have multiple things. So if you look at that next page with the group A members, you can tell there's 5 of them there. The 3 of the 5 claimants are cancer claimants, some with multiple things going on. And then you have a multiple sclerosis and a cystic fibrosis piece, and all with some hypertension or, comorbidities going on as well. Right. And since I can't see you, if there's questions, like shout out as I'm going through these. And then for the disease management opportunities, the B1 section, that's on the next page, the higher risk class. You will notice that that you do have, some people in, and this now separates it. You got 39 members. It shows you how many are employees, which is actually the majority of yours, versus spouse versus child. It separates it into male and female. Excuse me. And then it goes into the actual claim percentages and the relationships. And then the bottom right side shows prevalence of the disease. So you have 15% have asthma, 15% have coronary artery disease, 3% have COPD, which is the breathing pulmonary disease, 33 have diabetes, 77% have hyperlipidemia, and 74% have hypertension. Hyperlipidemia is your high cholesterol, hypertension is your high blood pressure. And then the next page, again, I'm not going to spend a whole lot of time on this. This is just the breakout of your population, how many are split by each of these. And it shows the total members and then the total amount actually paid. And then if you flip to the next page, this is it didn't, for whatever reason, work out. It didn't print out one didn't print out the actual, the other one didn't print out the benchmark. I don't know why, but I can fill that in for you. The disease prevalence by disease, the asthma, the benchmark is 84.8. You guys are actually at 48.7, so really low. Cardio was 26.5 for you guys. Again, the benchmark is at 34.7, so it looks like you're doing better than the benchmark. COPD is 8.8. Again, you're doing better than the benchmark. Diabetes is 53.1, so you're getting closer to what the benchmark is. Your hyperlipidemia and your high cholesterol are the two that, or hypertension are the two that seem to be the highest of the two, and that's 199.1 for the high cholesterol or hyperlipidemia, and the hypertension is 203.5. And then on the amount, the cost paid per member per year in thousands, the asthma is actually at a rate of $3.09 per member per year. The benchmark is 8.6. Cardio is 9.2. Benchmark is 20.7. COPD is where you are higher. It's 46.5 versus a benchmark of 23.9. Diabetes is 8.1. Benchmark is 14.2. Hyperlipidemia is 4.5, and the benchmark is 10.5. And hypertension is 9.2, and the benchmark is 11.3. So you can see that while the last two, your number of people are higher, the dollar amounts that they're spending on that is not as high. So that's a good thing. And then on the COPD, I think you can see on one of the previous pages, you did have, I think there's probably one person that seems to be driving that, because you have a total of 2 members, but you have a pretty significant total amount paid. So I think it's probably one person that is driving that up. And then the next pieces that go on to these is now taking each of those for the asthma, cardio, COPD, diabetes, high blood pressure, high cholesterol, and now splitting them down into, okay, if you look at the bottom page, what are some of they call them care gaps, and some of those definitions, I actually, this is the first time you'd seen that, I actually included the appendix, so you can actually see and look at the, some of the questions and answers on, why these particular things matter to have these care gaps closed. So for the first one on the COPD, again, the very first one is fine. The second one, you have 2 people that had a sporivia or Provent in the last 12 months, or even a spirometer testing, which is a big deal for the COPD. So it's stuff like that, that just encouraging people to go, now that they have a diagnosis of a particular disease, to just be mindful to be getting these tests so that you can make sure that you are on top of stuff. So as something happens, they can, usually treat something with medication. They can alter existing medication. It's those constant touch bases with your physicians just to make sure that nothing has changed. And then for the diabetes, this was another one that I noted when I was looking through. It didn't come up as significantly higher. As a matter of fact, it was lower in both the cost and the number of people with the disease. But I did notice that one of the things that's called out here as a care gap is patients without claims for glucose testing supplies in the last 12 months, which we want to make sure that people are going ahead and testing their blood so that they don't end up in the hospital or in the emergency room, and that they can lead healthy lives. And one of the things that has been put into the plan in the last 18 months, 2 years, for your Blue Cross plan is there's a program that you can actually get testing strips as part of the Blue Cross Blue Shield claims, and they send you a separate meter that's theirs. That meter, you can get these test strips, and the test strips otherwise have gotten to be very expensive. And so what we were finding is sometimes that was the reason, is people didn't want to test as much as they should or at all because they didn't want to pay the price for the testing meters. This is all part of a claim charge that is actually at no cost to the employee. There's a claim fee that comes through as part of a claim, but it isn't a charge that they get charged to their deductible or co-insurance or anything. And that then they can test and they will monitor. It's a system that is hooked up. And so if they do test and they notice that it is unusually low or unusually high, it actually sends a signal back to the provider and says, there's John Doe out here that just got a really low reading of 56 or something like that. They will actually call and make sure that, okay, are you doing okay? Is there something, did you just exercise and maybe you need some juice? Did you, what's the problem? These people, this is all they do all day, every day. Most of them are either diabetics themselves or are, living with a diabetic. So they're pretty passionate about this. And it also has a program within there, if the person wants to, that you can give them a name of somebody so that if they can't get a hold of you, you just had a reading of 60 and they can't get you on the phone for anything, they will actually, again, if you've given them the name and if you've approved this, they will actually call out to that other contact person and just indicate, we just got a really low reading and now we can't get a hold of them. Are we sure everything's okay? So it's that extra piece, especially for people that are, just starting with diabetes, that this is really helpful. But really anybody, again, for the cost of the drug. So that just is one of the pieces that I thought it's already part of the program. It's built in, maybe some additional education on that piece so that, when somebody calls and asks them, are you interested in joining, they would be a little bit more familiar with the program itself. So I digress.
Cindy, I've got a couple of questions on that. This is Jim Horstman.
Can you hear that, Cindy?
I can.
The first question is, with these gaps, can we address these by going directly to these individuals who are showing up as numbers here, saying, you ought to be doing this or that?
No, I wouldn't.
General
Yeah, no, just because of all of the privacy and HIPAA things, that's not what I would encourage at all. It's mostly education. Did you even know that you had this other program out there, putting some, bulletins out, saying, there's this program out there. If you have a wellness meeting, in generalities indicating that, we have a diabetes plan out here. If somebody is interested, we have some flyers, we have some educational information. Here's the things as a whole that we were finding we need to work on as a county. And, it's the high cholesterol piece. So, here's some of the things that we're going to be helping with. But to reach out directly to the person, some people, it kind of depends on the person. Some people will walk into your office and say, I'm having this issue, or somebody called because they had a question on this, and they'll be very open. Others just really don't want you to know that information, and that is totally their prerogative.
Right. My other question then is with respect to the diabetes monitoring system you were talking about. That's a no cost to the member. Where's the information on that we could pull up and against these people?
I can send, at the end of the meeting, I can send you some flyers on that.
Okay, thank you. Because I know at the last meeting, people were talking about how expensive it becomes for diabetics. Any kind of help we can find like that would probably be welcome.
Yeah. The biggest thing that I had heard is they get very attached to their own little meters, and they will have to change to a different meter. But again, I know that the test strips have gotten ridiculously expensive. And so you have people that are not testing, or certainly not testing as much. And this way, they actually, when they can tell, okay, you've had these kind of readings, so you've used this many test strips, they'll just automatically send you a new supply when they think you're getting low. Or you can call them and tell them, okay, well, two of them fell in the, water when I was trying something or something like that. So you can call them and get more as well.
Okay, thanks. Yeah, if you could send that, that'd be very helpful.
Sure.
I have a question on that. When it comes to the supplies itself, is there any way to shut off the option of the phone calls, like within a certain range? Like, is there a way for you to, my personal preference is I don't want to be called unless I'm below a certain number or above a certain number. Is there some way to dial in a range for an individual person?
I have not gotten that question before, so I will have to check with them. I would think so, because as I said, this is a very personal thing that they're looking at, your whole record. And you can get the record then from them and take it to your physician. So I can't imagine that they couldn't do something like that. But I'll ask that question and send you the response when I get it.
That'd be fantastic. Thank you.
I'm just writing a note here. One
Yeah,
second.
I just know that I go high a lot when I work out, and I don't necessarily want to tie up the resources if they're calling me because I'm higher than I should be when I know I am, and I purposely do it during certain times of the day. So I wondered about the range situation. Yeah.
Okay. All right. No, I can absolutely find that out, and then I'll get back to you.
Thank you.
That's a really good question. I haven't heard that question before. So, okay. And then, any other questions on the diabetes or on anything? Again, the hyperlipidemia, is patients without lab tests in the last 12 months. You had quite a few more than that. Now, if you do tests, for the wellness piece, and you're doing some of those wellness tests, at the county, those are not here. These are just the ones that would come through the actual medical claim system. So these might be a little skewed, but still, for people that have high cholesterol, they should be checking in with their physicians. So again, it's getting people to allow themselves to be monitored a little more closely by their physician. And then the last one is the hypertension. And actually, while it was higher with the number of people, the number of people that didn't have that without the diuretic test in the last 24 months was actually lower for you than the norm. And then the patients receiving medications was a little bit higher, but not consistently higher. So, and you only had one person that didn't have an office visit in the last 12 months. And then the last piece goes into the wellness pieces. Those were the people that were dancing right along. They didn't have any conditions. We just want to keep them healthy. And the biggest thing that I noticed here was that they didn't have the women's mammograms were for both the people that are over age 49 and the women between 40 and 49 were higher than the norm in both of those. Everything else, I think, was below the norm. So it just, is maybe some education on the mammograms. And I don't remember, I should have looked. Do you guys have the behavioral health member rewards program for Blue Cross? I don't remember if you do or not. If you don't, that might be something else that we look at. And what that does is if they can go someplace else that is a lower cost area, even with things like mammograms, colonoscopies, those type of things, that even if it is preventative and they don't have to pay anything for it, if they go someplace that is a lower cost than the hospital, which is usually the most expensive place to go, then they actually get a check. Obviously the county gets quite a bit of savings from it, but they actually get a check for something. And that can be anywhere from $25 all the way up to $500. I've never seen a $500, but I have seen several $300 ones go out. So that might be something else. If you guys are not already doing it, and I can look that up.
Lee County is involved in that.
Oh, okay, good. Then, yeah, maybe it's just something that we try and promote that a little bit more and make people recognize that that includes things like your mammograms, so that they could, actually be getting paid for doing this. Okay. And then the last piece is just the piece on some of the drugs and then the top drug classes. I didn't see anything that was any different than I see with any of the other groups. Your anti-diabetic, your migraine pieces are always, going to be towards the top of the list. So, all right.
Perfect.
And that report, I don't know that report, doing this even every quarter, but maybe, every 6 months or every year to go through this and just check and see if anything has changed is probably a good thing to look at.
Sure, appreciate that update, Cindy.
Good.
So next on the agenda is Lori Miller and the Employee Wellness Committee.
If you want her to keep going, she can. I mean,
Well,
look at whatever you want
it's
to
all
do.
right, yeah. Let's do this, and then we'll go on. Because that's the history part for me, so.
Okay.
All that, so.
Well, our employee wellness committee, I'm looking for new members. So if any of the departments are able to send somebody else, that would be great. It seems to be we can't. It's dwindling, I feel like. It is going well. We have our biometric screening last October was amazing. With that being said, we reached package A or package C, which then in turn, if we do submit all the correct paperwork by June 30th, we are looking at $64,000 coming back to the committee. So with that money, we just had a committee meeting last week. We have purchased 3 more drinking fountains that are for the bottle fills, and we've purchased a new treadmill. And we are donated some money to a 5K that will be coming up, and going to be sending out an email in regards to if you participate, pay for it, and prove that you finished, we will pay for your entry fee for that. We are also in the process of a bike rodeo. We donated 4 bikes to the sheriff's department for a bike rodeo because wellness starts as a child. And so we donated 4 bikes towards them. What else did we do? We do have our highway pick up trash. We adopted a highway, so that is happening April 24th at 8:30 for anybody that wants to attend and pick up garbage on the side of the road. It's all about wellness, walking, picking up, and volunteering. that also helps, I believe, with wellness. So I think that's all I have to report for the wellness committee at this point.
You had 3 more water fountains installed.
We purchased 3 today,
There's the
so
top.
they are due to come in next Tuesday with then the availability of getting them installed by the maintenance department. So that I think is
And
A
they're not
good thing.
full water fountains, right? They're just the
yeah, they're
top.
just the top. They're called like replacement taps. So
More
they
cost
just sit
effective.
right on top,
Yeah.
and then you could still use it as a drinking fountain, but also use it as a bottle fill.
Sure.
So
It was a lot cheaper than the
Actual
it
full.
was, the actual full was a lot. We got more of like 2 for 1
yes,
to fill just the top, and so be able to use it as fuel function. So I don't know if it's not a lot of it.
Any questions for Lori?
thank you.
Absolutely.
Thank you.
She's
Great.
kicking butt, taking it.
I love the wellness committee and what it brings back to Lee County. So really happy with that program.
Things are happening, for sure.
Good job.
Thank you.
Okay, so now we're back to you, Cindy. And we're into the new business, and it's really new business, old business, because what you're gonna do is educate me as far as, and Mr. McLean sitting here, as far as the relationship, the history of Gallagher's involvement with Lee County, and what you do for us, and how our insurance is structured, and all that kind of thing. So I'll let you take it back and on your way.
Are you there, Cindy?
Sorry, I was on mute.
Oh, you're fine.
Oh, we thought we lost you there for a minute.
But I was saying some wonderful things. We actually, for Gallagher is actually the broker for the IPBC group that you guys are a part of. The IPBC and Gallagher kind of started out together way back in 1979. And it is for the purpose, it's about 140 municipalities, townships, counties, forest preserves, those kind of entities brought together, and it's because the state of Illinois allows this. There's actually a state law on the books that allows the municipalities to join together for insurance purposes. And then that provides some economies of scale. So for, groups of your size, you can actually get some of the thing that I was talking about with the diabetes is available for Blue Cross for people that have 500 employees or more. But because you're part of the IPBC, you can participate in those type of programs. And so, one sec, there we go. And so being part, then Gallagher works with IPBC and has had that relationship, I think, since 1979. That we are the broker for the IPBC. So for like the next piece that's coming up on the MetLife to Delta Dental, we actually went through a RFP process to determine is the MetLife program the most cost effective, the most advantageous, does it have the most network availability for you? Is it providing the services that we wanted it to? And that's where Delta Dental actually ended up with, I think they have a stronger network, and there was some substantial cost savings to it. Some of the other pieces on the side for the prescription drugs, we just put in the Save On program. That is for the people that have really, really high medication drugs. Those drugs can actually participate in a program where the employee doesn't, and these are sponsored by the drug companies themselves. The employee doesn't have to pay anything for that particular drug, and now the county also gets to share in some of those savings. So it's programs like that that we're always trying to look at and make sure that, you know, it is providing the best service, the most cost-effective programs, the richest benefits, you know, that it's that balancing act between, you know, the cost of the benefits, you know, for the, we'd negotiate with the medical, you know, so the Blue Cross Blue Shield plan, and for the stop loss carriers, we go ahead and negotiate those rates. So I think for this last year, it actually was a positive for you guys because you ended up with a 2.6% increase on the medical and actually a 3% decrease on the dental. So it's those type of things. The insurance structure is set up, you know, the IPPC does use both Blue Cross Blue Shield and United Healthcare. Blue Cross Blue Shield is certainly the lion's share of the IPPC, but it does allow to have both. So the and the other piece that I'm sorry.
Can we ask a question real quick?
Yeah.
And that is, we keep referring back to IPBC. What does that acronym stand for?
The Intergovernmental Personnel Benefit Cooperative.
Gotcha.
Sorry, I should have started with that.
Intergovernmental Personnel Benefit Cooperative.
Yes.
Thank you. Okay.
Right. And the as I said, some of the other structure, when you join together with that, there's a lot of things that larger entities can have access to because they can spread the risk over a multiple of people. So even when I noticed one of the things before all of the lockdown occurred and we didn't have one of these meetings, one of the things that they were doing was they called it Scenario 6, where it used to be that each of the individual subpools got rated by their little subpool. What was being determined was within the subpools, you had people that were historically bad running, you know, poor experience and historically good experience. And you know, any group is going to have a rotation. They usually say every 3 to 5 years, you'll have a good year, you'll have a bad year. But within that time, that period, you don't want to have the other people in the subpool having to constantly uphold one particular group, or vice versa, have one group covering everybody else. So that with the Scenario 6, it moved it so that you were more in line with the size group that you had rather than the geographic location. And that also included some saving for you guys along the way. So, you know, again, that's kind of with the structure. You guys are in a subpool called Q-TIP. I'm learning all these acronyms. But that is, you know, for the kind of the western side of the state, but for the rating purposes now going forward, you're going to be in the tiered group that is more based on the size of your group. So does that kind of answer what you needed?
So, okay, so what we gathered out of that, and maybe I've got a couple questions, but we're looking at a 2.6 rate increase.
That was last year.
That was last year, from last year.
But Arlen asked me earlier what it went up, and I couldn't give him the numbers right off the top, but she just said that.
Yeah,
So
you just said.
Yeah, 2.6. Mm-hmm.
So, now, IPPC is, if we're talking about the pools, now IPPC is not the underwriters. Who is or are they? Do we underwrite? Does IPPC do the underwriting for our insurance, or do we have that done by a larger entity?
It's actually a kind of a staged piece. Blue Cross Blue Shield as your medical carrier and Express Script as your drug carrier would do it for all of the IPVC.
Okay.
So for, the 12,000 people that are in, 12,000 employees that are in the IPVC, Blue Cross Blue Shield would run, and for the PPO, it is I'm using a lot of acronyms, an ASO, a self-funded plan. So they would give a claim charge and then say, we think that the rates would be about, rates would be about this much, but you're responsible for whatever claims come in. Given that information, then Gallagher does have underwriters that work, I think he actually works pretty exclusively on the IPVC group. And he takes all of the group information now and splits it down saying, okay, well, knowing that this is what my overall is, and this is what they think the overall cost is, who's been doing better, who's been doing worse, and then develops a loss ratio report based on the individual group's experience and blends it with, because a group that is 100 lives isn't fully credible. You're going to have, as I said, bad years, good years. So you blend that with the overall, and based on the size, as by the time you get to about 300 lives, you're way more credible than you would if you're 50 or 75 lives. So there's a weighting there that says we're going to base this much on your own individual experience, this much on a blend of the group, and that's determined by the size of the group you are. The rest of it, you still have protection under this cooperative arrangement, because if you have a particularly bad year, your first 50,000 is your responsibility. After the $50,000, then that gets blended with everybody else, and everybody else kind of contributes into that pot. And then anything over 500,000, which is the stop loss level, is totally taken off for anybody within IPVC, and you have stop loss coverage for that. That was a really long explanation, but did that answer your question?
Yes, it did.
Okay.
No, that was very much what I was looking for.
Okay.
Anybody have any other questions for Cindy regarding structure, history? Jim, you good?
Yeah, no questions. Thank you.
All right. Okay, then we have, so thank you for that, Cindy. Very, very much appreciate that. That was informative, and it gave me I'll probably have a lot of questions. I tend to have a lot of questions on these kind of things, but that gave me a good basis to go from.
Okay, that's good. And the other part, especially when it's the numbers, you have to almost stop me. I tend to be a numbers geek because I actually started in the insurance in underwriting. So I kind of am a numbers geek.
Yeah.
So you just have to stop me. It's like, yeah, this is too much information, Cindy.
That's great. No, you're giving us a lot of good stuff. So very much appreciate it.
Okay.
Okay, we do have a question from Arlen.
What's our membership? It looks like we went up to 226, and first year members, the total current numbers 263. We had an increasing number in total in the last 3 years.
Did you hear that, Cindy?
I did. It kind of came in and out. Can you repeat it?
What is our total membership as of right now?
1 second. I think that was on one of the first stages. 1 second here. Oh, as of now, though.
Well, I mean, it doesn't have to be today's date.
Right.
Okay. Well, as of the end of the year,
End of the year,
in the average covered membership was 258.
258.
Roughly.
Yeah, roughly.
Thank you.
Okay, the next thing on our agenda is the MetLife Dental to Delta Dental, effective July 1st. Is that yours, Cindy?
I didn't have my name after it, but I certainly can speak to it.
Okay.
It is, as I said in my, comments above, we went out for a full RFP on the dental. It was decided that, both with the network as far and the, cost, it was the better idea to move to Delta Dental. So we have been in the process of working with Delta Dental, reviewing all of the plans. Because you are an ASO plan, self-funded plan, they are taking those, and your plan of benefits will mirror exactly what the MetLife did. We're going through line by line now, and if there's anything that is different, that is called out that they suggest, then I would be reaching back to you guys to ask, okay, do you want us to move? Do you want us to just keep it the way it is? But there really has been very little in the way that they could not administer or didn't think that that was a good thing. So for your employees, they shouldn't really see, other than the fact, and this should make them happy, unlike Met, where they didn't get an ID card and they did have to use their social security number. Delta Dental will be providing in June ID cards mailed out to people's houses, and you do not any longer have to use your social security number. There'll be a unique ID that'll go along with the Delta Dental program. And they'll be getting more information, and I'll send out, we've done a template example email that you guys can use, modify, do whatever. We're thinking you should probably send it out probably the end of May, beginning of June, because it indicates that, please don't throw out anything that you get from Delta Dental thinking that it is garbage mail, because you probably just threw out your ID card. So I will be sending that, as well as, as I said, we're going through with Delta Dental. As soon as they have your plan reviewed, I send out a plan highlight sheet that, you guys actually sign off on.
Perfect.
I have one, is there any cost difference for the employee and or the county with this switch?
Your overall renewal went down a little bit. That was what made it the -3%.
Thank you. Dental down. It's what?
Vision is the only thing paid directly by vision is the only thing paid directly by the employee.
The medical and dental split.
Okay, the next, any more questions on dental, on the switch? Okay, hearing none, the next item is the county plan open enrollment date, July 1st, 2021. And go ahead,
Let me
Lori.
just clarify, it's not open enrollment for Lee County on July 1st. Open enrollment takes place in October for
Well, that's
us.
what I thought. I thought
This
that was-
It's
is to go
just-
over the rates.
It's just, that's when the new rates come into effect, but effective 1/1 for Lee County.
Right. So why is this on the agenda? I mean, was it this?
Well,
It's letting you know that there are new rates in effect on July 1, but the
Right.
county's not going to see that until January 1.
Right. So there's no information. You have no information, Cindy, for us right now on rate information or an idea?
Well, the rate actually the rates will actually change. The IPPC's rates change as of July 1st. You guys actually make that rate change then, it sounds like, for a January rate, but the July is the rate change and that was the 2.6% increase and the -3%. And this would be an eligible open enrollment period for the people that did, for whatever reason, didn't want to stay with Delta Dental and wanted to drop. that it is an open enrollment period for them, for that. But it's just for the dental, it wouldn't be for the medical.
So on 7-1 is when you're saying that it's the 2.6% increase?
Correct.
It was 3% decrease.
Effective 7-1, but county does it 1-1.
The county makes up for it. I think you guys do
Okay, now I know.
an adjustment then as of 1/1 and kind of estimate. You guys are about, you have like 6 months at one rate, 6 months at an estimated rate.
That is correct.
That's
So the 2.6 that's mentioned, that is the rate we're anticipating or will be or be announced in July that will become effective January 1st of 2022.
correct.
Thank you. I was under the impression the 2.6 was actually what was announced last year that came effective January 1st of 21. So the 2.6, so, okay.
Yeah. Again, there's probably almost a 50-50 split now between groups that are in the 7-1 bucket and groups that are in the January. And so for the groups that are in January, I think what happens most of the time is there's January numbers that come out that are kind of based on, this 2.6 and any estimate going forward. So you're kind of in a perpetual catch-up period.
But, at the same time, Cindy, a 2.6% increase is tremendous compared to the rate increases that we've seen for how many years?
Eh.
So
Yeah, absolutely.
I'll take
And-
a 2.6% increase anyway.
I'll remember that.
We'll take a 1% more than 2%, but hey, remember that more.
At least you didn't pick on the -3. I don't know that I could do that many times.
No, we'll keep the -3.
Okay, any other questions in regards to the July 1st date and the rate announcement? Okay, hearing none, then we have discussion on 1095-B forms will no longer be automatically printed and mailed.
Cindy, we just saw that in the newsletter. That's the only reason why we put that on there, but we just wanted the employees to know that they would not be receiving that in the mail anymore.
Yeah.
That is just it. What it is proof of insurance that you need to do with your taxes, which no longer really needs to be filed with your taxes, but correct for now. So, as of right now, they are not going to be mailed at a later date like they are. If you want it, you need to go on and print it. So that's
Correct.
the only reason why that was on there, Cindy. Thank you.
Mhm.
All right, that's all the agenda items that we have. Is there any other items that the committee would like to bring up for discussion? I don't have anything else.
Where's your camera? I do have
So
new
we'll have-
biometric dates set for, can you give me that like October? They are going to be October 21st and October 28th. Hopefully same location. I have that call in at that Hope Bible Church, and I already have the same company booked for those 2 days. So still going with that, still going with the $150 something. Not sure it's gonna be a gift card to Walmart this year.
Or Lori's sanity, I hope.
So that's all I got.
Okay, so for next meeting, we'd be looking at July. We want take a shot at getting the meeting set. So it's always kind of nice to have them done before our regular board meeting. Be on July, would be the 15th. Would we like to shoot for one of the 12th, 13th, or 14th? Anybody have a preference?
Cindy, how about you? What is best for you?
Mondays are usually our meeting days, so probably, I'm looking at July. Let's see what this one is. Yeah, I could do the 13th. I can do the 13th or the 14th. I have a meeting scheduled for the 14th, but I can have somebody else take that.
So 13th, anybody have a problem with 13th? All right, well, then let's go for July 13th. Particular time?
I didn't know if the 2 o'clock worked better for you guys.
I want to go no, because that's the middle of my day, but that's okay. Sacrifice for
Well,
you
we can
guys.
go earlier at 11.
We can do,
We can
I mean,
do,
morning.
we can do morning, we can do it
Nine,
at 9,
Morning.
we can do a 9, 10.
Let's do a 9.
That's, I mean.
9 o'clock, okay.
9 a.m.
Is
okay?
that okay, Cindy?
It is,
All
that's
right,
fine.
Awesome, thank you.
As long as I can be on the phone as opposed to driving out there.
Well, and let's hope that our technology is working. Yeah. All right, we have the next meeting set on July 13th at 9 a.m. Is there anything else good for the cause for the committee? All right, hearing none, entertain the motion to adjourn. Moved by Miller, seconded by McLean. All those in favor, signify by saying aye.
Aye.
All opposed, motion carried. Thank you, Cindy, so much. Thank you, everyone, for, sorry about the technical problems, and we'll try to do better next time.